He's the Divisional Director for Specialist Medicine at Royal London Hospital. He co-runs the joint MDT with the hemoglobinopathy team for the Northwest London to optimize care for patients awaiting transplant and those who have received one. In addition, he was the past chair of the European Society of Organ Transplantation's Education Committee and co-chaired the SBC for the ESOT Congress in 2021. I'm delighted and welcome Dr. Thuraisingham for making time to do this session. He's incredibly busy. He's going to do his talk, and I would suggest you put your questions on the chat because he may not be able to stay right till the end of the session. So if everyone else can mute, over to you, Dr. Thuraisingham.
Thank you very much. I'm going to try and share my screen. It's loading up. So firstly, thank you very much for inviting me. Is it starting to share? Can you see that now? Okay, great. Yes. So thank you very much for inviting me to give a talk on this subject. I think I gave a talk on a similar subject, which is why Ragda, I think, suggested I speak today. And actually, when I was doing the research for that talk, I was drawn quite to the fact that sickle cell disease is really sort of underrepresented in terms of interest and investment in the world. And this data is based, this publication looks at the impact in Africa, where, you know, children rarely live beyond the age of 5 with sickle cell disease. So it's obviously a huge problem, which perhaps is invisible to us. And why is it invisible to us? Well, I think there's an element of racism that has been certainly highlighted in America around sickle cell disease and around the investment in sickle cell disease. This article in New England Journal highlights the fact that cystic fibrosis affects about 1/3 few Americans with sickle cell disease, but gets 7 to 10 times the funding for research. So it's a Cinderella subject. And I think even in Up to Date, it highlights the fact that institutional racism may play a role in the poor outcomes associated with patient sickle cell disease. And in the UK, this has been taken very seriously, and this all-party parliamentary group have looked at this, and this makes for some sort of harrowing reading when you read it, to look at the experiences of these patients. So I think it's spotlight's been shone on it after a long time, and absolutely rightly so. My interest actually goes back in this to 1991, where I was an SHO in this very same department I am now, and had the first publication. It was the New England Journal, and it's been downhill from there. Never reproduced anything quite as good as that ever since. But it was looking at anemia. This was when erythropoietin was first coming in, and looking at how it could be used in sickle cell disease patients. And then we published further on this back in 1993 about looking at it to do with renal transplantation here and sickle cell disease. So I suppose I've been thinking about this for a while. And what's the impact? I mean, you all know this, so I won't rush through it. But from the kidney point of view, I will rush through it. But from the kidney point of view, about 60% of people in the UK over the age of 45 with sickle cell disease have evidence of renal damage, so they have microalbuminuria. And of those, 4 to 12% will probably develop end-stage renal failure. And in other countries where sickle cell disease is more prevalent, perhaps like in Jamaica, sickle cell disease, chronic kidney disease is a very important cause of death in the more elderly survivors of sickle cell disease. So the impact on the kidney is not negligible and certainly needs to be thought about. The way I think of it is you can think about kidney transplantation, which is what my talk's going to focus on, in a few ways. You can think about people with these conditions, both homozygous and heterozygous sickle cell, as donors, as either living or deceased, and then as recipients. So that's the way I want to break it down. And there's no data on sickle cell disease, patients with sickle cell disease donating their kidneys as living donors. And I think, given what I've said about the impact of sickle cell disease and the kidney, I suspect very few people would want to entertain this. Certainly not with the current, certainly not currently. In deceased donation, I don't think there is an issue. There's the odd case report of a patient with sickle cell disease who has died, who's donated their kidneys, and the kidneys have worked reasonably well. There's very little data, so I'm not going to talk much about that. In terms of deceased donors and people with sickle cell trait, I don't think there's an issue. So again, I'm not going to talk about that. There's very little on that, but again, I'm not going to talk about that. And finally, somebody who's sickle cell trait receiving a transplant, I don't think there's much to be worried about. So again, I'm not going to talk much about that. But what I'm going to talk about is a little bit about people with sickle cell trait donating, but spend most of the talk about recipients of people with who have sickle cell disease. So this is a principle which I think most nephrologists think about when it comes to transplantation. And these are not absolute numbers, but it gives you some idea of how we decide whether someone would benefit from a transplant or not. So when we're assessing people, this is what we think about. And it's based on the fact that if you look at the relative risk of death here, in somebody with a transplant in blue versus staying on dialysis in green, what this shows is that on the day of your transplant, your risk of dying goes up. Obviously, you're having an operation, you're going through an anesthetic. This is for general, but also applies to sickle cell disease. It goes up. Then over time, that risk comes down. And then beyond this point, which will vary, the risk is lower. Each day, risk of death is lower for people with a transplant compared to people staying on dialysis. Obviously, that's why we do transplantation, because there is a benefit, survival benefit. However, when you've had a time when the risk is higher, you need an equal area under the curve when the risk is lower before you can be showing benefit from having had a transplant. So the way we assess people is when they come in, we decide whether they're low risk, medium risk, or high risk. Okay, so if they're low risk, we can see the peak risk of death is lower and they recover much more quickly and are benefiting from the transplant much earlier. The medium risk is a bit higher. And for the high risk, you can see the risk of death is much higher. And it may take a while to get down to this point, and you may not show a survival benefit for people with a transplant. But don't forget, we're also transplanting for quality of life. So for these two groups, there's good evidence that there's likely to be a longer life and a better quality of life. Not for all, because some people will succumb early, but not for all. But in general, we can advocate transplantation because there's a better quality of life and survival benefit. In this group, we cannot show a survival benefit, so we're only transplanting for quality of life here. And then there's a significant number of patients, and if you think in dialysis populations in the UK, it's only about 25 to 30% of patients who are actually on the transplant list. The rest we think are above there, and so we do not recommend transplantation for them. So when we're assessing patients, we're going to think, are they on this line, this line, this line, or above this line before we talk about transplantation. And how do we decide that? Well, that's based on comorbidities. So how frail they are, whether they've got diabetes, systemic disease, and sickle cell disease obviously pushes you up this line. So if you're young, you might go up to this line or this line. And if you're an elderly patient with sickle cell disease and lung disease and all the rest of it, you might be above this line. Okay, so that's the way we approach the question of whether transplantation should be considered or is of benefit to the patient. So what does the data tell us about sickle cell nephropathy and homozygous sickle cell disease and transplantation? Well, this is an old paper now, it's over 20 years old, that looked at the US registry, where it compared patients with sickle cell disease to a huge number matched that were not patients with sickle cell disease. And you can see here the 1-year graft survival was similar. And at 3 years, though, you're starting to see a difference in graft survival. So patients with sickle cell disease, their graft survival being poorer than those without. If you look at mortality, though, so why are they losing their grafts? So this is not death censored. So if you look at death censored, so if you look at mortality, you can see that patients with sickle cell disease weren't surviving as well as those without. So could this account for this poor survival? Because we look at graph survival, either absolute or death censored. So this implies that if you remove the mortality element, that the patients with sickle cell nephropathy tended towards improved survival compared to staying on dialysis. So that's the key question, really, is not whether patients are whether patients do better or worse than those without sickle cell disease. The question is, if you've got sickle cell disease, what's the best treatment? And this hinted, although didn't reach statistical significance, that patients with sickle cell disease are better off with a transplant than compared to dialysis. Later publications supported this even more, with 10-year survival with a transplant at being 56%. Compared to 14% on dialysis. So if you had sickle cell disease, then and were thought to be fit enough, don't forget these are select populations. Not everybody goes on the transplant, is felt to benefit. So in this self-selecting population, it looks as this transplantation provided a survival benefit. And in most of these studies, it doesn't compare transplantation towards versus dialysis in the whole population. It compares transplantation compared to people who were thought to be fit enough to have a transplant but didn't have it. So it's comparing more like with like in terms of comorbidities. So you can see that transplantation appears to provide a survival benefit compared to dialysis, and that the survival benefit appears to be improving with time. So in this cohort, it was 56%, whereas in this cohort, it's 70%. So we seem to be getting better at keeping people alive with transplants with sickle cell disease. Again, this data from British Journal of Haematology looks at this again. So this is the graph survival if patients with sickle cell disease compared to those without. And you can see most of this is accounted when you censor for patient death, the graphs appear to survive just as well. So the poorer outcomes are due to patient death, not necessarily poor outcomes from the graft itself. So therefore, assessment of these patients when they go on the list is really important. And what do we look at? So we look at general health, and frailty increasingly is showing to play a really huge impact on how well people do after a transplant. We know there are particular issues related to the heart with sickle cell disease, with the chronic anemia taking toll, iron loading, and pulmonary hypertension. There's obviously liver issues, chronic infection and hyposplenism play a role. Again, with lungs, sickle lung and pulmonary hypertension will play their role. And sensitization. So I want to talk a little bit about sensitization. So with kidney transplants, we are particularly worried about HLA sensitization to allow us to match for patients to receive organs that they're not sensitized against. So this is data we actually produced 10 years ago looking, this is not in the sickle cell population, but in the general population, that if you received a transfusion, you are 4 times at risk of developing antibodies against HLA, which narrows the scope of kidneys you're eligible to, which translates to longer waiting times. This is for dialysis patients. There is some data in sickle cell disease in pediatrics where 34% of people who've had more than 3 children who've had more than 3 transfusions were sensitized, mainly against class 1 rather than class 2. So your patients with sickle cell disease are obviously going to be transfused more than patients. We try and avoid transfusion in our non-sickle cell patients for this very purpose. In your case, and with your patients, you don't have that luxury, so there is an increased risk of sensitization. And how do we think about this? So I think the way we're thinking about this locally is that transfusion does maintain reasonable hemoglobins, and we try and maintain as low a heat sickle percentage as possible, and so patients have better overall physiology. But that's at the cost of iron loading, sensitizations against blood group, making blood matching more difficult, and against HLA antibodies. But I must say, we've shifted away from this concerns and more in favor of transfusing to maintain this, maintaining the reasonable hemoglobins, good physiology and cardiac status, and low sickle percentage. So the way we operate is trying to maintain reasonable hemoglobins on dialysis. So certainly hemoglobins of above 80, trying to maintain sickle percentage less than 30, or measuring it, being more accurate, maintaining sickle hemoglobin A of greater than 70 at all times. So, and we achieve this either with top-up or exchange transfusion programs. Certainly on hemodialysis, topping up seems easier than exchange transfusions if they're already on machines and is easier to do. But I think what's changed and what that means is we hardly ever now have to do an exchange or top-up transfusion at the time of a transplant. We used to be rushing around trying to get these organized when the patient's called in for a kidney. Now we very, very rarely have to do that because we are keeping people well maintained on dialysis. Obviously, perioperatively, we maintain hydration, but all of this is slightly less important when your sickle percentage is less than 30 anyway at the time of going to theatres. And again, trying to maintain temperature, body temperatures, and not cooling the kidney and things are also less of an issue now than they used to be. So what is the risk early? Well, obviously you can start precipitating crises when people start making their own hemoglobin, as opposed to being reliant on transfusions. Very early, if you've had too much sickle hemoglobin around, you can get intrarenal sickling and infarction. Obviously, these patients, as mentioned earlier, have ongoing cardiac and pulmonary issues, which may be stressed with fluid loading and stuff around the time of the transplant. Late, if recurrent disease, so sickle nephropathy can obviously recur in the kidney. There's the theoretical risk of antibody-mediated rejection because these patients are sensitized against HLA pre-transplant. And also, increasingly now, we are completely cognizant of the fact that post-transplant transfusions, we know from a publication for one of my late colleagues, can increase sensitization and so put you at risk of developing antibody-mediated rejection, which will shorten the life of the graft. And as mentioned, you can return to crises. So often our dialysis patients, because of making very little of their own hemoglobin, don't suffer with crises. When they're transplanted, crises recur because they're making sickle hemoglobin again. And actually, this is illustrated by that paper, this case report I mentioned right at the start of this particular patient who was being transfused regularly here and on dialysis. And when EPO came in, we tried her on EPO, and you can see had no hemoglobin response at all. But post-transplant, she started making sickle hemoglobin again. You can see a marked reticulocyte response. And she started getting crises again. And actually, this patient, this was over 20 years ago, unfortunately died. So I guess what we do here at the London is we have obviously a multidisciplinary approach with the dialysis team being involved, the sickle team and the sickle network, because we transplant for Northeast London. So I work with a key sickle lead here and we run a meeting every 3 months, virtual MDT, and we tie in with the sickle service at the Homerton Hospital and at Queen's and King George. So all the hospitals where patients flow to us for transplantation, we have an MDT with our sickle teams. So that seems to work quite well every 3 months for people who are on dialysis and on the transplant waiting list. So it seems to work very well. Included in this is a nephrologist, which is myself. We've got a waitlist coordinator. We work closely with the HNI lab, which is our tissue typing lab, to look at the sensitization status of these patients and obviously the transfusion teams and the sickle day units for the working up the top-up transfusions versus exchange transfusions, etc. So it's a huge, huge network of people involved in trying to optimize these patients. In terms of improving outcomes post-transplant, so we are quite aggressive about our exchange transfusion program post-transplant. So pre-transplant, as I say, if they're on hemodialysis, we may be more topping up unless the iron overloading is a significant issue. But certainly post-transplant, all of our patients go on to an exchange transfusion program just about. We can be thinking about, we're not doing this yet, but we can be thinking in the future about bone marrow transplantation and kidney transplants, and then also whether there are ways of increasing HbF. So this is data from London that all the London centres contributed to, showing exchange blood transfusion versus non-exchange blood transfusions. And you can see here the 10-year outcomes are much better with exchange blood transfusions post-transplant. So these are 34 patients who were transplanted over a 20-year period, and looking at their outcomes, those with exchange blood transfusions versus those without exchange blood transfusions. And you can see the non-sickle cell or the average general population survival here. I must confess, though, that this is more than, there's an era effect here as well, as the practice changed from no exchange blood transfusions towards exchange blood transfusions over these 20 years. So there may be an era effect over and above that of the exchange blood transfusion effect. But certainly we can get much better outcomes now than we were having before, partly because we know more and partly because of exchange blood transfusions, I think. And this again reiterates the fact that the poorer outcomes we see are based on patient death rather than graft survival. And I think this speaks to perhaps more aggressive transfusion during the pre-transplant phase, so patients in a better physiological state, I think. So in terms of moving outcomes in the future, I guess with bone marrow transplantation gaining more of a foothold in sickle cell disease, we may be seeing more of these followed by kidney transplants. So you can envisage today patients have a bone marrow transplant and then have a subsequent have a kidney transplant. With deceased donors, this has happened where they harvested bone marrow from a patient from the same deceased donor at the kidney and done sequential transplants. And with living donation, you certainly can see this happening. But I guess the thing to remember is that if it's siblings, then the siblings will have sickle cell trait, and that might have implications for them in the long term. And I'll discuss that a bit at the end. So there's exciting future here with bone marrow transplantation coming more into the sickle cell arena. In terms of increasing HbF, there is some publication showing better outcomes with hydroxyurea post-transplant. And there's a publication showing that mTOR inhibitors, which can be used in transplantation, which are used in kidney transplantation, drugs like rapamycin, in combination with tacrolimus, which is our mainstay of immunosuppression, can increase HbF, which hopefully will mean better outcomes. But this has not been replicated. There's just one publication indicating this. I'm not going to go through this, as you know much more about this than I do. And there's not much, as all these are fairly new therapies, there's not much yet looking at the impact of this on transplant outcomes. And this is a useful summary, which Clare Sharp, who spearheaded the London publication I showed you earlier, a useful algorithm which you can see, and I'm happy to share this slide so you can look at it. You can look at this reference, which I think is a very useful way of looking at how to approach kidney disease and sickle cell disease. I focus mainly on transplantation, but you can see the whole algorithm here is quite helpful in terms of the approach to kidney disease in general. And for the last part, I've raced through this, but for the last part, I just wanted to talk a little bit about sickle cell trait, and living donation, because one of the things we know is living donation provides a much better outcome for any patient compared to deceased donor. And so we used to look very hard for patients with sickle cell disease as well, looking for living donors. And it wasn't clear as whether we have used in the past donors with sickle cell trait and not really thought much about it. And the traditional view, I think, certainly amongst nephrologists, was sickle cell trait from the kidneys associated with reduced concentrating ability, so nocturia and all those kind of things which we know about. And there was a slight increased risk of renal medullary cancer, which if you're donating one kidney and have only got one left, you may want to think about, but that's a very rare cancer. So for this reason, we did not think twice about using patients with sickle cell trait as living donors. But, and in fact, if you look at policy, this is a 2007 publication in the US showing no screening policy at all for sickle cell trait. Some screened in practice, and the minority would exclude patients with sickle cell trait as kidney donors. In the UK, 20% had a policy to screen, but all would consider using them as donors. This was back in 2012, 10 years ago. And so the guidelines currently suggest you need to think more about this, but it's not contraindicated. But this publication a few years ago now really did change the way we think about this. And I'll just blow this up and show you in more detail. What this shows is in the general population, the decline rate of kidney function in the different categories of patients. The reference group here, this is patients with sickle cell disease. And this was the thing that really made us think long and hard, is this is patients with sickle cell trait. So this is over 15 years. And these are not people with kidney disease. These are healthy individuals. So in the normal population, we know that patients lose GFR at a rate of about 0.9 mils per minute per year. The thing that did slightly worry us, or does worry us now, is in sickle cell trait. You can see they use it at a more accelerated rate, 0.45. So another 50% increased rate of loss of function. So now we do warn our sickle cell trait patients, if they're going to donate, donors, that there is an increased risk of them developing kidney failure if they were to donate. Because when you donate a kidney, you lose half your GFR. That remaining kidney does compensate to about 60 to 70%, but they're starting in a lower baseline than they would have if they had two kidneys. And then if you're losing GFR at a faster rate, there is a risk of end-stage kidney failure. So we don't say it's an absolute contraindication, but we say it's a relative and depends on the age of the donor and all that kind of stuff. So it's something we definitely take into account now when counseling about donation. And so that's a change in practice over the last 5 years. So just to finish then, just to say sickle cell nephropathy is associated with poor outcomes and dialysis, and transplantation outcomes are worse than other causes of kidney failure. However, if you've got sickle cell disease, a transplant, and you're fit enough, a transplant offers you better outcomes than dialysis. Exchange transfusions and an aggressive transfusion program before transplantation we think is beneficial, and after transplant definitely we think there's evidence that that's beneficial. And I guess this, for those where this is more a nephrology question really, we think that you do need to be cautious with living donors with sickle cell trait. And I'm happy to take.
Thank you, Raj. That was a really, really good talk. Sorry, Eva, were you going to say something?
Yes, I was just going to say we do have a few questions. I see he's just joining us now. I must have
Yeah.
cut off. But I don't know if you wanted to wait until the end for the questions, Nandini, or you're happy to do it now.
We'll do it now because Raj has to leave shortly. Raj, I'm going to kickstart with a question that it's to do with your post-transplant exchange transfusion program. Now, how long do you leave them generally? The data shows really good response being on an exchange program. Is there a time scale that you leave them on?
No, we start them on it straight away.
Yeah.
And depending on their need, between 4 and 8 weeks, we keep that going right from the start till, well,
indefinitely.
We just keep it. Yes.
Wow.
Yes,
Okay.
yes, yeah.
Okay. So that's really useful. And is there like higher doses of EPO pre-dialysis for sickle nephropathy that is recommended?
Well, because we aggressively transfuse, we hardly use EPO at all, because they're, and whatever hemoglobin they'll make will be sickle hemoglobin, right? So that's why we just aggressively transfuse now.
Yeah. Okay. So we've got a question from Barbara Bailey from the community centre asking, is there anything they can do to reduce kidney damage?
Yeah, so apart from your maneuvers with HbF and trying to get HbF levels and all that kind of stuff up, blood pressure control, ACE inhibitors will help, and transfusion programs, reducing this. Now, I know there's a balance between iron loading and transfusion, but if that's something to consider. I guess it's something you need to weigh up as to whether, no doubt, if they're well transfused and have no sickle, low levels of sickle hemoglobin, then their sickle nephropathy would be less impactful. So it's a balance between how long you want to transfuse these people for, and the risk of iron loading and chelation and all that kind of stuff. But in terms of general measures, blood pressure control and ACE inhibitors undoubtedly are things to get in early and start using, and obviously monitoring them right from the start for things like proteinuria, and then introducing ACE inhibitors early.
Yeah. Okay, that's really helpful. Can I just open the floor for anyone to ask questions?
I'd be interested to know how many of your transplants are from live donors and how many are deceased donors, and what are the chances of someone actually getting a kidney if they're on the list just awaiting a deceased donor?
How long? So are you talking about sickle in particular, or are you talking in general?
So I suppose thinking about the sickle cell patients, but it may be the data is not available for them separately.
Yeah. So anecdotally, from my experience, because most donation comes from family members, we have less living donors, because often it's siblings and stuff, and we have less living donors because either they have sickle cell disease or they have trait, and now we're more cautious with sickle cell trait. Deceased donors, in general, they tend to wait longer. So it's not because of various things. One is the ethnicity, being Black, and because of HLA matching. The common HLA genotypes in the Black population are slightly different from those in the white population. And if we're trying to get, in general, the way organs are distributed is according to matching. So we know Black and Asian patients wait longer, and also because we know donation rates amongst the Black population is much, much lower than amongst the white population, not both in absolute terms and relative terms as well. So refusal rates for donation are much higher in Asian and Black potential deceased donors. So that's one thing. So they wait longer for that. And the other reason they wait longer is because they're sensitized, because they have antibodies. So most blood donors also, it's commoner amongst, it's rarer amongst the Black population, is my understanding, and Asian population. So they're often getting blood from white patients, and those are the very tissue types they're being sensitized against, in terms of the same population also donating their kidneys. So the waits tend to be longer.
Oh, thank you. That's really interesting.
Josh.
Hi, thanks. Yeah. Thanks for a great talk. You mentioned right at the beginning that although transplant outcomes look a bit better if you just look at the transplant, there's a higher death rate in these patients. And I wonder if you have had much information on the causes of death.
I don't have from the literature, and I guess it's the same things in that sickle patients have a shorter life expectancy than the non-sickle patients in general population. So it'd be the same thing. So don't forget, transplantation only takes away the renal mortality, it doesn't take away any of the other mortality effects. So if you've got lung complications or whatever, those things are still going to continue. And prior to the prior to the aggressive transfusion policy, they start making sickle hemoglobin again, don't they, after a transplant? So potentially going back to that, again, it's all anecdotal, I'm afraid. I don't know, the literature, I don't think tells us, but certainly from personal experience, we know sickle crises come back more after a transplant than when they're on dialysis, because they're making their own hemoglobin again. And obviously that increases the complications. So I don't have any more detail than that, apart from, because survival is, the general outlook is poorer for patients with sickle cell. Life expectancy is shorter for sickle cell patients compared to non-sickle cell patients. You're going to see that in the transplant, reflected in the transplant outcomes as well.
Brilliant, Raj. That's been an incredibly useful session and very helpful. And we'll be driving some change of practice in our unit. So thank you very much, Raj, for that and your time.
Thank you very much for inviting. Thank you.
Okay.
Thanks again.
So we're going to move on then. Claire, are you doing the next session?
Yes, I can do. I'm conscious that we're a little bit short of time, so I'll abbreviate it a little bit because I want to make sure we get Regarda's session in as well.
Yes.
But yes, I will. Okay. If you're happy, I'll go ahead and start sharing the screen.
Yes, I'll do a quick introduction. So the next talk is on preventing renal failure in sickle cell disease. We've got Dr. Clare Samuelson. She's a hematologist with a hemoglobinopathy interest, and she's based at Sheffield, which is the HCC for the North East and Yorkshire. She's the chair of the UK NICWA Special Hematology Scientific Advisory Board, and she's also the training program director of South Yorkshire. Her particular interest includes genome editing and other novel therapies for patients with sickle cell disease and thalassaemia. Over to you, Claire.
Thank you, and thanks for the kind introduction. So I'm going to be focusing on preventing renal failure and preventing progression of renal abnormalities in our patients, because as we know, prevention where feasible is going to be much better than attempting cure with its associated risks. Can you see the presentation okay? Is that working?
Yes,
we can.
Yeah, fantastic. Yeah. So I can't see you, but please do feel free to either interrupt as we go through, or we'll have questions, I think, jointly at the end. So I'll briefly outline the pathophysiology of sickle cell nephropathy and the spectrum of complications that we see in our patients, much of which I think has already been addressed by Raj's talk. So we'll try not to duplicate that. We'll look at whether or not we can predict which patients are going to run into trouble with renal failure and how we should be monitoring them. And then, most importantly, we'll talk about preventative strategies and also when to refer to your renal specialists. So this slide's busy, but all I want you to take from it is the fact that sickle cell nephropathy is very multifactorial in its causes and also affects all areas of the kidney. So it's generally caused by variable combinations of anemia, vaso-occlusion, so restriction in blood supply and oxygenation, and also the chronic hemolysis that we see in our patients with release of reactive oxygen species and oxidative damage. And this affects the whole kidney from the glomerulus through the proximal tubule, distal tubule and collecting duct. And as a result of this, most individuals, by the time they reach adulthood, do have at least a degree of renal dysfunction if they've got HBSS. And what we're trying to do is prevent, where possible, progression to chronic kidney disease and this irreversible unselected proteinuria. Most people, almost universally, will have inability to concentrate the urine normally. So that's the first thing that we see in sickle cell disease, and that's associated with this high baseline EGFR. So bear in mind that by the time we're seeing a normal EGFR in our patients, actually that is abnormal for them, and it represents a significant decline. In most people, that will progress to at least microalbuminuria, but that can be reversible in the early stages. And then, as I've said, what we're trying very hard to do is pick up patients in these early stages and prevent progression. And most of these figures Raj has already alluded to, and I'm very grateful that they're similar. So I think we're looking at the same papers. But just to highlight that over 10% of deaths in adults are at least in some way associated with renal impairment. And it's the primary cause of death in almost half of patients who reach the age of 60 or older. And although we're primarily concentrating on sickle cell nephropathy and chronic kidney disease today, we should just acknowledge that our patients also have a higher risk of other complications, including nephrotic syndrome, renal tubular acidosis, papillary necrosis, which usually presents with hematuria and pain, but we need to be careful to pick that apart from the risk of medullary carcinoma, which is rare but a very nasty malignancy where that occurs. And this graph nicely summarises the findings of quite a few of the larger studies of patients with sickle cell disease, and looks at their EGFR trajectory in comparison to the normal population who are represented with these stars. And I think it's very helpful here that not only have we got HBSS patients, but there's actually a line representing HBSC patients from the Walk Fast study. And we see that while they start with not quite so abnormal an EGFR, it's still significantly different to the healthy population. And it also declines at a faster rate than the healthy population, although not quite as fast as patients with HBSS. So can we predict which patients are going to run into trouble with sickle cell nephropathy? Well, since most adults have at least a degree of renal dysfunction, I think the most important thing to say is there's no patient in whom we don't need to worry about that. But there are some factors that make people higher or maybe slightly lower risk. So individuals who have HBSS or S-beta-0 thalassaemia have the highest risk of sickle cell nephropathy. Those with S-beta plus, a little bit of a lower risk, and those with HBSC are going to be in the middle. Co-inheritance of alpha thalassemia or higher baseline HbF are somewhat protective, as are a number of other genetic polymorphisms that we don't tend to test for. And in terms of poor predictive factors, other than the genotype, I think all of these are just markers of bad sickle cell disease, really. So someone with a high hemolytic rate, a lower hemoglobin, frequent admissions in painful crisis, signs of pulmonary hypertension. So that's bad sickle cell disease. So it's not surprising there'd be an increased risk of nephropathy. And hypertension, of course, is a risk factor even outside of the sickle cell population. So we should be monitoring these patients carefully, as has already been discussed, and at least at annual reviews, we need to make sure we're checking the blood pressure, looking at the EGFR, checking the urine. Albumin creatinine ratio is more sensitive, but in patients where there's already been some progression, the protein creatinine ratio is also informative. And in terms of preventing nephropathy, we can't forget how important the basics are. So good blood pressure control, ACE inhibitors or angiotensin II receptor blockers. And they would be your first choice antihypertensives, but actually in patients with significant proteinuria, they should be used regardless of the blood pressure where tolerated. Good hydration. We know there's an increased risk of AKI when patients are admitted with veno-occlusive crisis. And thinking about, not leaving patients on months and months of ibuprofen or diclofenac if they've got chronic pain and a degree of renal dysfunction. Oh, and it's always important to think about other causes as well. So, it's easy to put everything down to sickle cell disease, I think, and that's one of the dangers in this condition. But we need to make sure there's not something which may actually be more treatable, like a UTI. So we can't forget the basics. And then hydroxycarbamide, already discussed briefly, really, really good drug, as we know, in sickle cell disease, and works in a variety of ways. And really, all of our patients with HBSS or S-beta naught need to be offered this drug. And if they're not on it, there needs to be a good reason as to why they're not on it, because we know that it not only improves the rate of acute complications, but it also reduces chronic organ damage, including renal damage, and extends life expectancy. So really good drug. Evidence for hydroxycarbamide in preventing renal dysfunction. Some of this comes from the baby hug study in young children. We know that when hydroxycarbamide is started really early, you see better urine concentrating ability, a reduction in the renal enlargement. We know that it will also reduce microalbuminuria. And in adults, we've got data, although non-RCT data, to show that the adults on hydroxycarbamide have lower rates of albuminuria and better eGFR. So, just emphasizes how helpful a medication this is. With a few caveats, we're advised to avoid hydroxycarbamide if eGFR is below 30. And there is some really less evidence for using it in patients with HBSC or other genotypes, and that's the case for all sorts of indications for treatment in patients who don't have SS or S-beta naught. But there is some data, and I think there's enough for us to say with some confidence that we expect it will improve and will reduce the rate of progression of nephropathy, even in patients with HBSC. The role of regular transfusion, and this is outside the context of patients waiting for transplant. There's not really clear evidence. Mechanistically, we would expect that if you transfuse someone regularly and keep the HbS percentage down, that will reduce the rate of progression of nephropathy, but we don't really have robust evidence to back that up. But it is a treatment modality that we do consider in patients who are already on hydroxycarbamide, ACE inhibition, that have got progressive nephropathy. And I think it's already been well covered that we would look to regularly transfuse or exchange someone awaiting a renal transplant. Sickle nephropathy has been given as a primary indication for stem cell transplants in a number of adults, but also didn't consistently prevent progression. And in the new commissioning data, eGFR of under 40 is actually an exclusion criterion for a sibling allogeneic transplant. So when do we refer patients? Well, I think the first thing to say is it's really important to have a very good, close working relationship with your renal specialists. And we're very lucky in Sheffield to have Dr Regada El-Damanawi, who's our go-to nephrologist with a special interest in haematology. And we refer patients if they've got consistently declining eGFR, or if it's under 60, or if they have nephrotic syndrome. And we discuss a lot more patients than that in our regular MDTs. Of course, patients with hematuria need to go to urology to exclude medullary carcinoma. So in summary, renal disease is very common in patients with sickle cell disease. We should intervene early wherever possible to reduce and slow progression. Basics are really important, but do refer for specialist input where indicated. And that's a brief list of references. I'm very happy to provide more information or copies of references on request. Can you stop sharing? Thank you. Do you want to take questions at the end, Nandini, for both me and Regada, given time constraints?
Yes, I've just seen a email from him. He had to dash to the ward for an emergency.
Oh,
I'm not sure.
Regarda did. Oh, okay. Well, in that case,
not,
should we do questions now?
Yes. We could get started with some questions. So, Claire, I'll start again, only because it's an incredibly useful talk on sickle and renal disease. I've got quite a few of my patients who, it looks like it's nephropathy and anemia is kicking in, but just wouldn't have a bone marrow because they say, this is all sickle related, doctor, why are you doing a bone marrow? Or looking into it, what sort of what is your experience with patients, that there are some with the eGFR starts dropping quite quickly, and you haven't found any other cause for the anemia? What do you normally do?
So they should already be on hydroxycarbamides, ACE inhibition, optimal blood pressure control. So all of the basics. We'd be discussing them with the renal team in MDTs. We've got regular meetings with them and getting them referred, making sure they've not got something else going on, as you've alluded to. Because it's easy to forget, isn't it, to do think about myeloma in our older patients and things like that. And after that, I would usually be discussing the option of regular transfusion, being very honest with the patient that we don't have very good evidence for it, but we don't really have other options at that point. I suppose now we've got better access to transplant. If there's a matched sibling, that would also be a consideration for the younger patients primarily.
Is that less than 30, 35? Is that what you're thinking, young?
I mean, I've seen patients up to 40 discussed at the NHP for sibling allo. I'd be much less keen as they get older, and there's normally multiple comorbidities and organ dysfunction as patients even get to late 30s, unfortunately, particularly if they've not been on hydroxycarbamides, since an earlier age. But then I think, we don't have many more options, do we? So if they're on a regular transfusion program, it's really then the renal team will take over, looking at what stage they need to think about dialysis or think about transplant list. And I had a couple of patients awaiting transplant who were on regular exchanges. So that would be our usual protocol.
Yeah. No, brilliant. Yeah, no, we've got quite a few who've had transplant, at least closer to 6 to 8 patients who've had transplant. Some are failing graft on the second list. Oldest is our 64-year-old lady who's had her graft for a good few years now on an exchange transfusion ongoing, but waiting for a second kidney at the moment. But they are quite challenging to manage, especially with the when they get sensitized. And so anyone has got a question? Noemi?
Hi, thanks. That was a really that was a really great recap. In Oxford, we haven't got any renal physician who would like to take a lead on sickle cell, and we have tried really hard to get that, and they've specifically said no, just refer generally. So our patients are being seen by different consultants, and different things seem to be done according to me, whether they get a renal biopsy, who gets put on an ACE inhibitor, and I find that really difficult, and I'm not sure that my patients are getting the best care. Do you think we should be escalating that and going sort of super regionally if we can't find the expertise here? What are your thoughts on this?
Do you think you have any renal physicians who might be persuadable if
I mean, I've tried for years. No, I have. I mean, I can try again, but it's been renal and urology are the two things where we cannot get anybody to engage.
Oh, that's really difficult.
It's not just Noemi. Even in Manchester, we do have a renal physician who does see and start them on ACE inhibitor. If we don't send it to that clinician, they don't get started with with the proteinuria. Again, the talk from Raj about putting them on exchange transfusion post-transplant, we don't do it routinely for everybody. It's a bit hit and miss if they're out of region. So there's a lot. We've got a huge number who've had transplant, sickle transplant. So it is something that, after today's talk, I have to think about from, in terms of improving care, really.
Yeah, for sure, for
Yeah,
sure.
and I've got Josh sitting next to me who's saying set up an MDT, which so whether that would sort of draw people in, involve them a bit more, if they could either join your MDT, or if you offered to go to their MDT to discuss these patients regularly, it might be then someone starts to develop an interest. But my experience is it does make a big difference having the right person to refer to.
Absolutely.
And sometimes it's not even a referral, it's it's just a query. Do you need to see this patient? Am I missing anything?
Yeah.
What would you like to do?
Yeah.
So having those links, I think, is very helpful.
I think it's all the more that we need to have these links now after this talk, don't we, Noemi?
Yeah.
So definitely.
Yeah. If anyone else has any questions, it was a very, very useful session, Claire. It was great that you've put this together. Going to ask if anyone else want to ask any questions or anything at all.
We do have a question from Barbara asking, if patients cannot tolerate hydrocarbonide as a first line of defense, what other medications may be suitable?
I don't think we've got evidence that for anything else being protective or sort of disease modifying for sickle nephropathy. Obviously, you've got ACE inhibitors, but that's not directly disease modifying. That's more generic treatment for someone with proteinuria. Crizanlizumab, that we don't have evidence currently that it would do anything for sickle cell nephropathy. We've voxelotor, you might think about for the anemia side of things. I mean, our local experience isn't particularly positive of using it, but anecdotally, there are patients with renal associated as well as sickle associated anemia who have benefited. So that's something you could think about. And then you've got, the EPO, IVI, and support anemia as another option, but that's more generic renal management. So I don't think, unfortunately, we have a good answer to that. I don't really think we have very much to offer above the options we've talked about already, hydroxycarbamide, and then you're onto transfusions, really, to try and prevent the progression of the nephropathy before someone reaches the stage of needing dialysis. So I wish we had more to offer.
Yeah, I think the difficulty is if they don't start the hydroxy early, and once the renal function starts declining, you try putting them on hydroxy, it actually, the anemia can be a bit more of an issue. And that's one of the problems I've had with a couple of my patients who just wouldn't start hydroxy. But once the renal function starts deteriorating, they're keen, but you then struggle to increase the dose any more than what you can, because it just cause a bit of myelosuppression.
Yeah, and even patients who've been stable on hydroxy can sort of lose their tolerance a little bit as the hemoglobin comes down, as a combination of getting older, reduced bone marrow function probably, and the renal function as well. So, it's an excellent drug, but it's not, a panacea, unfortunately.
Yeah, absolutely. So I don't know if Dr. Regada is on the call.
No, I think she's still not managed to rejoin us. So if I could send her apologies.
Yes.
I wonder if we could reschedule her presentation.
Absolutely. We could do that in the new year.
And actually, we've used the full hour anyway.
Yes. No, amazing. I think the session's been really helpful. It'd be great if everyone could feedback and say if there's anything you want for the future sessions. We'll call it a day today. All right. Thanks, everybody, for joining in.
Thank you. Thanks, Nandini.
And happy Christmas and a happy New Year.
Thank you. Just to quickly say, there is a feedback survey just in the chat, and certificate of attendance will be provided for those who do give us some feedback. So thank you all so much.
Yeah. Bye now.
Great. Thank you. Thanks, Eva. Bye.